We're just going to quick go over teamwork and communication in healthcare. It's a really important topic when it comes to taking care of our patients, so let's get right into it. Foundation is basically just integrating everybody's perspectives, including the patient, to communicate clearly and have better patient outcomes. Just like a sports team, if everybody's not on the same page, it's going to be chaos on the field. It's going to be chaos in the workplace if we're not all on the same page when it comes to our patients' care. So, our main goals are to expand accessibility, promote collaboration and teamwork, encourage nursing to get into those leadership roles, transform education for nurses, diversify nursing. We want more men, we want more people of color, we want the nursing workforce to look like the actual population. And then we want to collect that data from the workforce and make sure that things are going the way that they should. So advantages in interprofessional teams, improved access and coordination of care. If we have physical therapy assigned to our floor, we can easily get physical therapy assigned for our patient. We want more efficiency. We want increased quality of community health services. We want to get those home care services in and get them working with our patients and make sure we're all on the same page. And we want to decrease complications, length of stay, and staff turnover. If we have happy nurses, we have happy patients. So we need to find ways to work together as a team and really get good patient care to the forefront of healthcare again. Team steps. It focuses on the team structure, who's on the team, communication. We want to communicate effectively. Leadership is there to guide and support team functions, not direct and demand. We want to monitor the situations and understand how the team's doing. And then everybody should have mutual support for and provide feedback to each other. If we think something is going wrong, we need to speak up and say it without being aggressive. We just need to make sure that we're putting the patient's needs first. So referrals and consults. Um, Consultations are just having another doctor come in and give an opinion, or a physical therapist, or occupational therapist, or any of a number of specialties. Referrals are where we're sending a patient specifically to that person to consult and maybe even take over a certain aspect of care. If a patient has new coronary artery disease and we're referring to cardiology, sometimes just a consultation where cardiology says, hey, I think they should be on these medications is acceptable, and the patient might never have to see cardiology again. But it might also turn into a long-term transfer of care for their cardiac needs. So it's important that we understand what those processes mean and that we ensure that patients get the care they need from the proper fragmented care. We end up with duplicate orders. We ended up with wasted resources. I don't know how many times I watched cardiology put a patient on a medication and nephrology immediately come in and get rid of it because it's nephrotoxic. So these providers need to learn to work together. It costs a lot more money. We miss out on patient needs, med errors, delayed treatment. All of these things can lead to those negative health consequences. Patients are unhappy because one provider tells them to do one thing, the next provider comes in and tells them to do a completely different thing. And it increases that risk of morbidity and mortality, especially mortality. If nephrology comes in and says, don't take that medication that cardiology put you on, but it was really necessary for their cardiac health, that patient could die of a cardiac comorbidity, and the nephrologist is none the wiser as to why the patient needed to be on it. I don't know how many times I've seen a patient put on a medication like Januvia where the intended therapy is to urinate out glucose, and the patient goes to nephrology because they have kidney failure, and the nephrologist takes them off of it because they're urinating glucose. So it's really important that we all communicate and we're all on the same page. Discharge planning. We want to begin discharge planning on day one. The minute that patient is admitted, we're already looking down the line to what's going to benefit them at discharge. We want to involve the whole team, the patient, the family. We want to know what that patient's needs are going to be and how can we meet them. We're going to be educating throughout the patient's contact with us. We're not just going to start discharge planning on the day of discharge, and we're not going to start education on the day of discharge. It's all going to be throughout. And then when we're getting ready to discharge the patient, we're going to make sure they have doctor's appointments. We're going to confirm that they feel ready to go home by themselves. and will provide instructions and maybe even home care to make sure that that continuity of care is there and the patient is safe at home. Interpersonal communication, this is where a lot of people struggle. A lot of people will either be passive or they will be aggressive or even passive aggressive. It's really important that we learn how to communicate in a very direct but not aggressive manner. We also have to make sure that we're documenting accurately, and with our document, we're not using anything on those do not use abbreviation lists, which can lead to patient harm. So we have the IS bar. IS bar is a standard to communicate between disciplines. It's a really great thing to learn how to do and to get used to doing, even just writing everything down that you're going to want to say when you're a new grad nurse. First, you want to introduce yourself. Hi, my name's Becca. I'm a nurse and I'm taking care of Mr. Jones. The situation: Mr. Jones fell on the floor this morning. Background: Mr. Jones has a history of cardiovascular disease. He also has a history of stroke and right sided hemiplegia. Brief evaluation of the situation. I took a look at Mr. Jones. I did his vital signs and they're all stable. However, he's kind of not 100% there cognitively. He's very confused as to who the President of the United States is at this moment. Recommendation: I would like to get a CT of his head to make sure he didn't have any kind of traumatic brain injury. And then when the physician gives you some sort of order, you're going to want to read that back and repeat it. Let's say the physician gives you a verbal order for a medication. All right, let's give him some morphine right now, and we'll do this, 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 and this. Make sure we're getting a full order and we are telling the doctor what we heard. If you do not tell the doctor what you heard and you heard wrong, you have the potential to harm a patient. So we're always reading back what the physician told us to do. Handoff reports. Traditional handoff was always in the nurse's station with nurses just talking back and forth about each other. It has a lot of benefit in that the patient is not hearing and interrupting. However, it has been discovered that there's a lot of communication gaps, and sometimes patients are being handed off that are not safe at the time of handoff. So the new thing to do is do bedside handoff. We are going to go right to that patient's bedside. We're going to introduce the oncoming nurse so the patient knows who's taking over their care. We're going to take a look at that patient right in real time, make sure they're breathing normally. Sometimes when you're doing handoff, it can take about an hour, and if you're doing that whole hour not getting any eyes on any of your patients, and then you're going to get your med pass started, you may not lay eyes on one of your patients for 3 hours. Bedside handoff eliminates that lack of eyes on your patient so you know what is going on in real time. It also involves patients and their care, which is so, so, so important. When bedside reporting was first started in the hospital that I worked in, I was one of the biggest detractors. I thought it was the dumbest idea I'd ever heard. But then we had a patient code at handoff, and the nurses were in the room, and luckily we had a good outcome with that because the nurse was right there and saw him decline immediately. So it's really important to do this bedside handoff, even if it feels awkward talking about the patient and overcoming obstacles. There has traditionally been a hierarchy in the professions. The physician is over the nurse. That is no longer the case. The physician is your colleague, just like the CNA is your colleague. Nobody is better than anybody else. We are all working together for the same goal. We need to know the team members' scopes. We need to communicate. We need to talk to each other and trust each other and understand everybody else's competence. If you don't think a team member is competent, maybe you want to watch them do it. And then we have to learn how to resolve conflicts. We cannot just go up and start yelling at people. We have to approach them in a calm, respectful manner. Workplace incivility. I'm sure every single person listening to this has heard the phrase nurses eat their young. I don't personally believe that this is true. I think some people have better personalities for teaching than others, and I think that's where this pervasive thought comes from. However, that being said, I cannot say that there are no bullies in nursing any way that I could say that there's no bullies in engineering, or in medicine, or in teaching, or in any other kind of career. Every career is going to have bullies, and it's important that we know how to deal with them. It's also very important that we don't start saying, oh, nurses, 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 it's because they're all women, they all eat their young. That is going to detract from our profession, and we need to learn how to not only cope with these bullies, but help to call them out and keep our patients safe. So, building a culture of respect, we have zero tolerance for bullying. There's zero tolerance for bullying at school. Um, Leadership has to commit to it. If somebody is getting bullied, we have to commit to protecting them. New employee training needs to be done on acceptable behaviors. New student training is done on acceptable behaviors. Every single student I have has to sign the sheet that tells that they understand what is acceptable and what is unacceptable. Formal ongoing training for staff, clear reporting procedures and accountability. We have to hold these people accountable for their actions. And then there has to be an organization wide commitment. It cannot just be Susan on the second floor has no tolerance for bullying, but Joe on the fourth floor, he loves to watch the girls go at it. So it's really important that we focus hard. Strategies for conflict. There's accommodation. Just yielding can sometimes be a strategy. If it's not something that's huge and yielding won't make a difference as far as the patient care and it'll just make things easier, then just yield. And I don't know why that has a middle finger, but it seems to fit. Collaboration. Talk to each other. Come up with a solution together. Compromise. Temporary middle ground solutions until you can get somebody else involved to help figure out a plan. Avoidance, just disengaging from the conflict. If it's something like I want to go to lunch at 12 and you want to go to lunch at 12:15, maybe just walking away and letting somebody else decide when you guys go to lunch. And competition is asserting power to achieve our goals, which is something we never want to do. We never want to assert that we have more power than anybody else. So, proactive communication, that cognitive rehearsal, it's just using things in your mind to determine constructive actions and positive outcomes and how you might react to things that people are saying in real time. It is not thinking ahead and coming up with your response while somebody else is talking. It's actively listening to what they're saying, taking that deep breath, and coming up with a way to respond that is beneficial to both parties. Emotional intelligence, so important to have. That self awareness, understanding your own emotions, regulating your emotions, taking those deep breaths and calming yourself down before you speak. Motivation, what are you motivated by? What are your goals in this interaction? Empathy, understanding other people's feelings, not to be confused with sympathy, where you're sorry for other people's feelings. Really getting inside their head and saying, okay, she's not usually like this. She's usually a lot nicer. I wonder if there's something going on that's making her be like this today. Social skills, just navigating those social interactions effectively and being a part of the group. So, in summary, collaborative healthcare is client centered. We're focused on the patient at all times. We are not focused on winning. We're not focused on who's better. We're focused on making things better for our patients. Then effective communication tools like the SBAR are crucial for patient safety. Until you get the hang of it, write everything down. And then just try to be emotionally intelligent and take those deep breaths before you speak. Maybe count to 10 before you speak to help yourself from making a statement that you don't mean.